Well, first of all, I would like to thank to the organizing committee for this very kind invitation. It's a pleasure and an honor for me to be here, to stay with you today, and to share some knowledge regarding the field in which I have been involved for the last 25 years. The role of ultrasound in gynecologic oncology. So I'm going to talk regarding the role of ultrasound in diagnosis. Basically, this is related to ovarian cancer. And then we will be talking about staging. And for staging, we will talk about endometrial, cervical, ovarian, as well as vulvar and vaginal cancer. And then a couple of slides just to show you that ultrasound is a very important tool to guide some invasive procedures in gynecological oncology. So regarding ovarian cancer diagnosis, probably all of you would agree that ultrasound is the best imaging technique for diagnosing ovarian cancer. The ovaries are not easily reachable to take a biopsy, contrary to the endometrium or to the cervix or vagina or vulva. So we have to invade the body of the lady to take a biopsy. And this many times is complicated. It's a really invasive procedure. And so we have to rely on imaging techniques. And ultrasound is the best one. We have several approaches using ultrasound for diagnosis of ovarian cancer, such as the expert examiner subjective impression, the use of some scoring or classification system, and logistic models. Well, expert examiner is based on the interpretation of the images by an expert examiner, expert sonographer, who established the diagnosis of malignancy or benignity regarding these features. When performed by an expert examiner, the sensitivity and specificity of this technique is very high, more than 90% specificity and sensitivity. And only about 4 to 10% of the masses will be considered as indeterminate. That's it. We can't say if the tumor is benign or malignant. There are a lot of scoring systems reported in the literature. However, nowadays they are absolutely deprecated. They are not using any longer. And in 2005, the IOTA group, which is an international group, focused on the differential diagnosis of adnexal masses using ultrasound, started to develop several different approaches for such a diagnosis, like logistic models, LR2, LR1, the adnex models, the simple rule classification system, the easy descriptors, and lately the ORATS classification. I'm going to focus on some of them. The simple rules are actually, they are simple approach. We have to assess several sonographic features of the tumor, and we are going to focus on some malignant features and some benign features. The presence of at least one benign features without any malignant features classifies the mass as benign. The presence of at least one malignant feature in absence of benign features classifies the mass as malignant. And when we have either benign and malignant or no malignant, no benign, the mass is inconclusive. And then we have the adnex model. The adnex model is a polytomic logistic model, not only for classifying the masses as benign and malignant, but also to try to establish the risk of the tumor being a borderline tumor and a stage 1 and a stage an advanced stage of epithelial cancer and a metastatic cancer. It's very easy to use. We can use this simple app in the smartphone, or we can go to the iota.org site to classify. Then we put the parameters which are included in the model: patient's age, type of center, gynecological center or not, maximum diameter of the lesion, number of papillary projections, and the number of locus, the presence of ascites or no, the maximum component of solid, acoustic shadowing, and CA125, and then we got that risk. In this case, the risk of malignancy is going to be 40%. But we see that there is 14% of a borderline tumor, 1.8 risk of metastatic tumor. So this is the annex model. There are, when we have to decide which is the best to use, clearly this meta-analysis from the group of, for Evelyn Mays, published in 2017, they reported that so far the pattern recognition by an expert examiner is better than the simple rules and the logistic models. There is no comparison today. There is no comparison the annex with simple rules or the annex model with pattern recognition. There are work in progress in that comparisons, but today we can't say if annex model is better than simple rules or not, or if it is better than subjective impression by an expert examiner or not. Anyway, the performance of annex model has been reported in these two meta-analyses, and when we select a cutoff of risk of malignancy of 10%, the sensitivity is about 94–95%, and the specificity is about 77–73%. So it reaches a significant high sensitivity. Very few malignant tumors are going to be missed when using this annexal model, but the specificity is a little bit low, but because we are going to have like 20–25% of false positive cases. Regarding ovarian cancer staging, I don't know how many of you are involved in ovarian cancer surgery, but probably you would agree with me that when analyzing the extent of the disease prior to surgery, we usually focused on imaging techniques such as CT scan and in some centers MRI. However, this meta-analysis reported in 2018 made clear that the sensitivity of CT scan to diagnose the presence of disease in some specific areas like a peritoneal involvement, like a diaphragm, like a liver, like lymph nodes, and large and small bowel mesentery involvement was pretty low, because you see in the slide that sensitivity, for example, for small bowel mesentery is just 24%. So we are going to miss a lot of cases with involved of the root of the mesentery. We will not see by CT scan. For this reason, in Prague, in Czech Republic, more than 10 years ago, Daniela Fischerova proposed the staging of ovarian cancer using ultrasound. And she proposed a specific method, a scanning procedure combining transrectal, transvaginal ultrasound and transabdominal ultrasound to detect where the disease is in cases of ovarian cancer. And you can see actually, oh, I see, no, this is tumor over the uterus, this is tumor on the pelvic side wall, this is a lymph node in the pelvis, this is the involvement of the rectosigmoid, this is involvement of the major omentum, this is a tumor here close to the liver, thank you, close to the liver, here the tumor, this is the stomach, this is the liver, this is a major omentum, this is again a rectosigmoid, this is a pelvic lymph node, and This is a para-aortic lymph node. This is the aorta. This is the vena cava. And this is a lymph node in between. This is tumor in the surface of the liver. And there are metastatic nodules within the liver. So actually, we started to think that scanning could be, ultrasound scanning could be good for staging ovarian cancer by imaging, by using ultrasound. So 2 reports here in 143 patients, this one from Fischerova, almost 400 patients, make clear that ultrasound is very specific to detect disease, but it has a low sensitivity to detect miliary carcinomatosis and to detect lymph node disease. This more recent paper in 2021 from a Polish group, 132 patients, reached the similar conclusions. So, but the point was, okay, is ultrasound inferior to CT scan to detect tumor spread within the abdomen in patients with ovarian cancer? So we performed a comparative study comparing ultrasound and CT scan. And sorry for this table, but when we compare sensitivity and specificity for at least 12 different anatomical areas, we didn't find any significant differences in terms of sensitivity and specificity. And when we compare the accuracy of ultrasound staging compared to surgical findings and CT scan staging compared to surgical findings, we observed that the accuracy of ultrasound was 71%, the accuracy of CT scan was 75%. Actually, there was no statistically significant differences. So in this study, we concluded that ultrasound performs similarly to CT scan for imaging staging in ovarian cancer. And this has been confirmed in a smaller series by Fischerova, very recently paper, but only 67 patients, that comparing the performance area under the curve for sensitivity specificity of ultrasound, CT scan, and MRI also. She compared 3 techniques. In all this area, she didn't find any statistical significant difference. So clearly, when you are trained on abdominal ultrasound and abdominal scanning, you can reach similar results than CT scan or even MRI. Regarding endometrial cancer staging, well, probably all of you know that staging of endometrial cancer is surgically performed, like in ovarian cancer. But a great debate exists regarding the need to perform systematic lymphadenectomy in tumors that are considered of low risk of having lymph node involvement. And this basically occurs when we have endometrioid grade 1, grade 2 cancers with no or less than 50% myometrial involvement and no cervical involvement. So literature is plenty of papers addressing how to evaluate myometrial invasion in endometrial cancer. Basically, we have 2 methods, 2 objective methods. The Carson's method is just a ratio between the endometrial thickness and the anterior posterior diameter of the uterus in the sagittal plane. If this ratio is above 50%, we do consider there is a deep infiltration of the myometrium wall, like this case. If the ratio is below 50%, then the case is considered to have less than 50% of infiltration. The other method is to depict a line in the sagittal plane, okay, dividing the uterus in the sagittal plane in 2 parts, and then measuring from this line to the deepest part of the infiltration, and from this lane to the serosa of the uterus, and then perform a ratio of these two measurements. In this case, is above 50, so deep infiltration. In this case, is below 50, so superficial infiltration. This is the way we can evaluate the infiltration of the tumor. But we can do that also by subjective impression. In this case, you see the myometrial endometrial interface pretty well defined, pretty well. So we would say here there is no myometrial infiltration there, or probably less than half my infiltration. But if you look at this case, you see the tumor here, and the tumor is very close to serosa here. So in this case, we would say this is a deep myometrial infiltration. No measures, just by looking to the mesh and by looking how the tumor invades the myometrial wall. There are also three-dimensional ultrasound methods proposed to establish the myometrial infiltration. And when we compare in this meta-analysis the different approaches, subjective impression, Carlson's method, and Gordon's method, we observed that there were no statistically significant differences between all these three methods. So in this case, you can use the one you want. Okay, obviously, Carlson method is very easy to perform, very reproducible, and this would be the one to be advised to use. Regarding three-dimensional ultrasound, the sensitivity and specificity, 85, 84, 82, is quite similar to that reported for either subjective, Carlson and Gordon's, 84, 82, 85, 80, 70, 78, 81. So clearly, this meta-analysis, I'm sorry, I'm going back. Okay, this meta-analysis clearly show that 3D ultrasound is not better than 2D ultrasound. So you don't need 3D ultrasound to assess myometrial infiltration. And, but the other point to consider high-risk case is not only the infiltration of the myometrium, but also the infiltration of the cervix, because then you go from a stage 1 to a stage 2. So, and this is a high-risk case, so lymphadenectomy or sentinel lymph node sampling should be done. So we wanted to assess that issue, and what we observed. What we observe is that the sensitivity and specificity of ultrasound is good enough. But at the end of the day, when you look at the most guidelines, in those guidelines, you will read is that MRI is the imaging technique to be used. The first choice to be used is MRI. So we wonder if that's really true, if MRI is better than ultrasound to detect deep myometrial infiltration and to detect cervical involvement. And what we observed in this meta-analysis published several years ago is that the diagnostic performance of TBS is absolutely similar to diagnostic performance of MRI. So MRI is not better than ultrasound, and it is much more expensive. And the same for cervical involvement. This is cervical involvement comparing TBS and MRI, and the sensitivity and specificity are almost identical. These two meta-analyses were head-to-head meta-analyses. In those meta-analyses, we just compare the diagnostic performance of both techniques in studies that use both techniques in the set of patients. So every single patient underwent staging by ultrasound and underwent staging by MRI. When we compare the results of those studies, we observe that there is no statistical significance. And this is why in the most recent ESGO, European Society of Gynecologic Oncology guidelines, is established for the first time that diagnostic performance of TBS and MRI are quite similar. So you can use ultrasound. And then we move to cervical cancer. Cervical cancer, if you look at what was told 20 years ago regarding ultrasound in cervical cancer staging, you see here ultrasound only to measure, only for measuring tumor size. But the MRI, it's the best technique to detect all things, lymph nodes, parametrial infiltration, and so on. But we already know from a long time ago, 90s, late 80s, that there is a clinical, there is a significant disagreement between the clinical and surgical findings, especially when talking about parametrium, because we can understage a significant proportions of reportedly stages 1B. I mean, 1B, yes, and 2A. And if you understage, if you don't detect parametrium involvement, you will consider that patient, in some cases, as candidate for surgery. And this is going to be a big mistake, because that ladies are candidates for chemoradiation treatment, not for surgery. So it's quite important to ascertain whether the parametrium is involved or not. So, and we can do that by ultrasound, and the answer is yes. Here you have a transverse view of a cervix with a tumor, and the tumor spreading, extending into the right parametria here. Same here. This is the ureter, and the tumor is very close to the ureter. This is reaching the pelvic side wall in this tumor. However, in this case, you see the tumor here. This is the tumor. And when you look at the parametrium, there is no infiltration. There's very well defined the parametrium. Remember, sagittal, I mean, transverse view of the cervix. Transverse view of the cervix. And then you see, in some cases, how the tumor is invading the ureter. This is the bladder. This is the ureter. And you get how the tumor is infiltrating the ureter. And then you will find this, hydronephrosis. So, certainly, we could evaluate parametrial infiltration by ultrasound. Also, you can detect bladder infiltration. Bladder infiltration is usually evaluated by cystoscopy. However, when you see here the tumor, this is the tumor of the cervix, this is the bladder, and this is the infiltration of the bladder wall. Infiltration of the bladder wall. But you can also detect the infiltration of the rectum. This is a huge tumor on the cervix. This is the corpus of the uterus. This is the rectum here. This is the posterior muscularis propria of the rectum. This is the sacrum. Okay, this is the rectal sacral space, and you see the tumor here. And if you look for the muscularis propria in the anterior wall, you will see you won't see that, because the tumor is infiltrating the rectum. Obviously, you can detect that by rectal examination too. Okay, but by ultrasound you can do that also. And again, you can evaluate the presence of lymph nodes. This is a similar case to the previous one I show you on the ovary. This is another intra-aorta cava lymph node. This is a lymph node in the bifurcation of the aorta, sagittal plane, promontorium here. This is the aorta. This is a common, in this case, right iliac artery. This is the lymph node here, and this is the another lesion in between the vein here and artery here, external iliac external artery. This here is the lymph node, so you can detect that by using 3D ultrasound, using the tomographic imaging. You can also detect the infiltration. So this is several slides from the cervix, from the cranial aspect to the caudal aspect. From here, this slide is here. This slide is here. This is in the sagittal plane, all right? This is the coronal plane, and this is the axial plane. So the tumor is here. This is the stroma of the cervix. The tumor is very close to the anterior serosa of the cervix, okay? But when you go down, you will see how the tumor is infiltrating the parametrium here. So the parametrium is infiltrated not there, but here. So by using 3D ultrasound, you can also detect the infiltration of the parametrium. And there is a meta-analysis, 11 studies, more than 700 patients, that established that the parametrium, the sensitivity of ultrasound to detect parametrium involvement is 62%, the specificity is 91%. The sensitivity of ultrasound to detect lymph nodes is 42%, 95% specificity. But again, the question was, okay, but we do still need MRI for this, and then we perform a new meta-analysis, 9 studies, close to 600 patients, comparing ultrasound and MRI to detect parametrial infiltration. And here again, ultrasound performs absolutely similarly to MRI. So ultrasound could replace MRI for detecting parametrial infiltration. And this is why in the latest guideline of the ESGO, it appears that the endovaginal transrectal ultrasound is an option instead of MRI for local staging of cervical cancer. For nodal evaluation, we do need, ideally, PET scan, because PET scan is much more sensitive than either ultrasound and MRI. But ultrasound and MRI have both of them similar diagnostic performance to detect lymph nodes in gynecology oncology. I'm close to finish because regarding cancer of the vulva, well, the main issue with the cancer of the vulva is to detect we do perform with high frequency probes, ultrasound transducers. We do estimate the size of the tumor in all 3 planes of the space. We do estimate the infiltration, how close to the deep fascia is infiltrating the tumor, if the tumor is reaching the deep vulvar fascia or not. And regarding the vagina, we can also detect whether the paracolpos is infiltrated or even the parametrium, the low parametrium could be also infiltrating, as well as the bladder or even the rectum. Here is an infiltration of the left paracolpum in a vaginal cancer. But the main issue, or one of the main issues related to staging either both, actually, vulvar and vaginal cancer, is the assessment of inguinal lymph nodes. So very recently, there is a group, the Vulvar International Tumor Analysis, the VITA group, who has proposed a standard approach for scanning the groin in order to detect lymph nodes in cases of a vulvar and vaginal cancer. It could be also performed, obviously, by any kind of cancer, but the presence of groin nodules in lymph nodes in endometrial ovarian cancer is very rare. It's not, and also is a little bit rare in cervical cancer. So using this is a normal lymph node in the groin. You see here, this is the cortex, this is the medulla, hyperechoic the medulla, hypoechoic the cortex. The cortex is thin, the medulla is thick, and normally the lymph nodes, a normal lymph node is oval in shape, and the longitudinal diameter is larger than the anterior-posterior diameter. Here, we do have some reactive lymph nodes. You see the cortex is a little bit thickened. This is the medulla. But this is not involved by cancer. However, when you have these lymph nodes, no medulla, okay, or like this, you see this high vascularization, several nodules, confluent nodules, lymph nodes. These are nodules highly suspicious for malignancy. So you can palpate the nodules, especially if they are in the superficial area of the groin. But when you look at the deep area of the groin, sometimes it's going to be very, very, very difficult. And finally, we can use ultrasound to do diagnostic procedures, like using the TrueCut for this adnexal mass, or fine needle aspiration and cytologic assessment in this cervical mass. And obviously, you can also use ultrasound to guide radiotherapy. Here we are inserting a colpostate within the uterus by ultrasound guiding, just to be sure that we don't perforate the uterus, and the colpostat is correctly placed for delivering brachytherapy. So thank you so much for your attention. I'm ready to answer any question that you could have. And again, thank you so much for your very kind invitation.
Thank you, Professor Luis, for this comprehensive